alaikum. Thank you very much for the invitation. Today, I am going to talk on the benefit of reducing blood pressure in case of mild hypertension. I like to start with the tale of an American president, and he is Roosevelt, the renowned president Franklin Delano Roosevelt. In 1937, when he was just 54, his blood pressure was found elevated to 162 over 98 millimeter mercury. And according to our current position, he was just having mild hypertension. But at that time, this was not recognized to be any abnormality. So no therapy was given by his personal physician, Admiral Ross McIntyre. And over the next few years, his blood pressure went to some extent more. And in 1941, the BP was 188 over 105 millimeter mercury. So he was having severe hypertension. And at that time, just scopes of treating hypertension was very limited. And he was offered just phenobarbital and massage as the treatment for the hypertension. Why? Because at that time, the concept was that hypertension is nothing but a compensatory mechanism of the body, and this should not be treated at all. Two renowned cardiologists of that time, the former one is Dr. Hay, he was from UK, and his statement in 1931 was that the greatest danger to a man with high blood pressure lies in its discovery, because then some fool is certain to try and reduce it. Find it just 90 years back from this time. And the second one was the father of American cardiology, Paul Dudley White. And in 1937, his concept was that hypertension may be an important compensatory mechanism which should not be tampered with, even while it's certain that we could control it. So that was the concept at that time. And accordingly, the president was not treated. In 1943 and 44, the president developed features of target organ damage like pulmonary edema and just cardiomegaly in chest X-ray and left ventricular hypertrophy in ECG, and also proteinuria. He was just treated by this time a cardiologist, Dr. Bruin, and he was offered low salt diet consisting of rice boiled in distilled water and fruit juice along with digitalis. And in 1944, the president had a series of strokes, ischemic strokes, and ultimately in 1945, on the 12th April, while he was just sitting before for a portrait, he had severe headache and suddenly he collapsed. He lost his consciousness. And when his blood pressure was just recorded at that time, this was found 300 over 190 millimeter mercury by his doctor. And then ultimately he died at the age of 63. And this was rather a young death for an American president. Why I have put this before you? Because this is the usual natural history of hypertension. It starts with mild hypertension and progresses through severity and ultimately leading to target organ damage and culminates into fatal cardiovascular events, including stroke. So hypertension is very, very important entity. And what is mild hypertension? Because today I am going to talk to you regarding mild hypertension. In the guidelines, there is nothing mild, but usually or the customary is that stage 1 hypertension and the borderline hypertension can be regarded as mild hypertension. So if we look back to the recently available guidelines, that is the guideline from International Society of Hypertension and also the European Society of Hypertension guidelines, according to them, if the systolic blood pressure is between 140 and 160 millimeter mercury, and the diastolic blood pressure is between 90 and 100 millimeter mercury, we can consider that they are having mild hypertension. Any of the two or both. You know that today is the time for ambulatory blood pressure monitoring and home blood pressure monitoring. There is a paradigm shift in clinical practice, and all the modern hypertension guidelines are in favor of using more and more ambulatory blood pressure monitoring and home blood pressure monitoring because they reflect more physiological changes throughout the 24 hours time. Does mild hypertension matter? If we go back to the evidence, just 90 years back in 1931, 39, there was evidence that in the clinical studies that along with the rise in systolic as well as diastolic blood pressure, even it is in mild range of today, there was increase in the morbidity and mortality. We know and we can recollect the renowned Framingham Heart study. And in that study, just the red circle indicates that the range of mild hypertension even leads to significant increase in the coronary heart disease mortality. And also, there was increase in the risk of coronary artery disease mortality and stroke in other trials like MR-FIT trial. So by this time, we are sure that mild hypertension is not really benign. If it gets chance, it will behave like a malignant one in future. Does treatment of mild hypertension have any impact of clinical outcome? In other words, should we treat or we should not treat? This is a very important, valid clinical questions. I am not going into a robust data, just I am going to place before you some meta-analysis. And this meta-analysis also dates back almost 30 years and at 20 years. And at that time, the meta-analysis found that even treatment of hypertension in all ranges may be beneficial in terms of prevention of cardiovascular bad outcomes as well as stroke. Now, what are the recent evidences? Just in 2015, another meta-analysis was published involving the renowned available RCTs related to the treatment of hypertension. And in that case, it was found that treatment of mild hypertension is likely to prevent stroke and death in patients with at that time. Just few weeks back, another meta-analysis was published in the Lancet. You know that the world famous journal Lancet publishes high quality medical information. And in that journal, in that paper, published this year, it was found that if 5 millimeter reduction of systolic blood pressure actually reduced the risk of major adverse cardiovascular outcome by 10%. And this was irrespective of previous cardiovascular disease and even at normal or high normal blood pressure. We are not even talking about mild hypertension. Normal or high normal blood pressure, if they are treated accordingly, ultimately there will be benefit in terms of reduction of MACE. So even mild hypertension should be diagnosed and treated, but how? If we look back the current guidelines, there are a good number of guidelines from the prestigious organizations of the world. Last year, International Society of Hypertension published a beautiful comprehensive guideline. And this year, another guideline was available from WHO. And this is the latest complete guideline from a prestigious authority like WHO. And just a few days back, another update was available from the European Society of Hypertension regarding the practice to measure the office and out of office blood pressure. The current trend is that you should use office blood pressure, that is the blood pressure machine which we are using in our office or at the chamber. Okay, but probably the more beneficial will be to adopt ambulatory blood pressure monitoring as well as home blood pressure monitoring for the diagnosis and further management of hypertension in all grades of severity. Sometimes our patients ask which blood pressure machine should be the better one. Or sometimes we are also in confusion in a realm of blood pressure machines available nowadays. We have got digital blood pressure machines, we have got aneroid, and the old is gold that was available in the Bangla cinema of Uttam Kumar and Suchitra Sen, the large mercury blood pressure machines.
Hello.
So
Hello.
now the time and the available evidence and the current guidelines are more in favor of using the validated digital blood pressure machines. But probably the best one is the mercury blood pressure machines that is still available in Bangladesh, but already banned in many countries of the world for fear of environmental pollution. So probably this is the time to adopt digital blood pressure machines more and more, but you have to be sure that your blood pressure machine is a good one, validated one. So how can we be sure that I am using appropriate blood pressure machine? There are some authentic ways. Some societies of the world like British Hypertension Society or German Hypertension League, they regularly updates their recommendation regarding the suitability and authenticity of the digital blood pressure machine. And there are two renowned international organizations that can certify your blood pressure machine. One is the stridebp.org and another one is the medaval.ie.blood pressure monitors. You can just easily Google and ultimately go to the websites of either of the two organizations, and you can place the brand of your blood pressure machine and also the batch number of your blood pressure machine. And then the website will give you directly their assessment regarding whether your blood pressure machine is validated or not. Mind it, available blood pressure machines, just 8% of the available digital blood pressure machines are validated by the STRIDE-BP. 92% are not validated according to their standards. So this is very important. Otherwise, we may be in false position and our patients will be in false position. This is the way you can go to the website. This is the regular update available from the one of the two renowned organizations like STRIDE-BP, and they have just put here the model number as well as the brand of the blood pressure monitor that has been validated by them, certified by them. Just an example. From the third year, we are using ALPK2 blood pressure machine, but certainly that was manual one. But this is one example of ALPK2 digital blood pressure machine. When this brand was put in the website, ultimately you are just looking at that the recommendation was not recommended and the device has not been clinically validated. So according to the authority, this machine is not validated. Probably we should not purchase and use this. This is an example of ABPM. I think over the next few years in Bangladesh, use of ABPM will go up and ultimately we have to adopt to ambulatory blood pressure monitoring more and more. What is the utility of home blood pressure monitoring? It is very simple. It virtually costs nothing extra. Just we have to make our mind and we have to say something to our patients. The patient can use a simple digital blood pressure monitor in their residence, and ultimately they should be advised to take blood pressure twice a day, one in the morning and one in the evening, before taking any blood pressure medication and also any exercise and meal. He or she should just measure the blood pressure 2 times each in the morning and 2 times at night. And he or she should average the two values, and ultimately the average value should be placed in a chart over the 7 days a week. The first day should be discarded And the second to seventh day values should be ultimately make further average to get the value. This is a chart for the patients and the healthcare providers that has been suggested by the Australian family physicians. Many of the authorities have provided these types of charts, and this is a very simple one. And ultimately, at the end of the week, we can make an average, and the patient can put this to their practitioner or the doctor, and the doctor can make a firm decision regarding the further management and the degree of control of their patient or not. By this time, we have diagnosed hypertension, and this is mild hypertension. And what to do next? As Professor Abdullah Choudhury, my teacher, had mentioned to you that there is no scope for seeing any cardiac abnormality as a single entity. Rather, this is the time to consider every cardiac abnormality as a global abnormality. So the patient should have scoring regarding his cardiovascular risk scoring system, and this may be mild, moderate, or severe. And then the patient then should further be analyzed regarding the presence of cardiovascular risk factors, hypertension-mediated organ damage, another nomenclature of which is target organ damage, and the last one is some previous diseases that patient may already have. So all the three parameters should be taken into consideration. Cardiovascular risk factors you are already familiar with. There are some addition and some subtraction from the known list. I am not going into details. And what about the target organ, hypertension-mediated target organ damage? This is very, very important. And there are some minimum that must be looked for. One is the presence of left ventricular hypertrophy, say in ECG. This is easily available, everywhere available in Bangladesh. And another one is presence of CKD, that may be by serum creatinine, and better eGFR, estimation of eGFR. You all are having smartphones in your hand, and you can just go to MedCalc and just put the values of serum creatinine and age and sex of the patient, and the website will give you a beautiful value of estimated eGFR. So you need not invest anything except for some few minutes in your clinical practice, and you have to set your mind to do something more authentic and more global. And ultimately, any other available measures of organ damage, say you can perform fundoscopy in your medicine ward to look for any retinopathy that may be due to hypertension. The diseases that are very relevant to the management of hypertension are presence of previous coronary artery disease, heart failure, stroke, peripheral vascular disease, and the new addition is atrial fibrillation, and also advanced CKD like CKD 3 or more, stage 3 or more. What scoring system we should use? The current recommendation by the International Society of Hypertension is the score system as was recommended by the European Society of Cardiology. We can use this. This is very simple if you practice this. This may not be the best one for we the people of Bangladesh, but still we have no other validated scoring system of our own. So we have to, if we are going to use, we have to use the score system. Laboratory investigations, I think you all know, and I am not going into the details. So by this time, we have already diagnosed and evaluated our patient with mild hypertension. Now it's time to treat. And the first and probably the most important one is to offer non-pharmacological treatment. That is the lifestyle modification, which be in terms of achievement and maintenance of ideal body weight. This is the most important one. Another one is heart-healthy diet. You all know this. Next one is salt restriction, especially no added salt. And the next one is potassium supplementation. These should be, you know that potassium and magnesium are the heart-healthy elements that are available luckily in fruits. Kola, banana is a very good source of potassium in our Bangladeshi fruits. And also increased physical activity and avoidance of smoking and smokeless tobacco. Find it for we, the people of South Asians, the criteria is even more strict. And for us, the desirable BMI is between 18.5 and 22.9, not 50, 25. So we are more prone to develop coronary artery disease. And the definition of abnormal obesity, central obesity, abdominal obesity is for male, the cutoff point is 90 centimeter, and for female, 80 centimeter. And this is, the value is even higher for the Europeans and Americans. But for us, the values are so strict. Now, this is the recommendation for the pharmacological treatment. What is the recommendation? In case of mild hypertension, if our mild hypertension patient has got high cardiovascular risk that has been assessed by using the scoring system, or my patient is having target organ damage, or if my patient is having diabetes mellitus, CKD, or cardiovascular disease, known cardiac disease, in that case, even in presence of mild hypertension, there is no scope for making any delay. We have to start pharmacotherapy by the side of lifestyle modification instantaneously, at that time, immediately, no delay, no observation. And if my patient with mild hypertension is of low to moderate risk category, no other features of target organ damage, and no other associated cardiac or diabetes or renal disease, only in that case we can wait. We can offer lifestyle changes for 3 to 6 months with regular monitoring. And if this is proven not to be sufficient, in that case, starting pharmacotherapy is mandatory to prevent future bad cardiovascular outcomes. And in case of grade 2 or more hypertension, there is no scope for delay. We have to start pharmacotherapy immediately. Regarding selection of drugs, what are the recommendations? You know that just there are a lot of pharmacological agents, and the first line drugs are calcium channel blockers, ACE inhibitors or ARBs, and diuretics. These three groups of drugs are the first line drugs for the treatment of uncomplicated hypertension. I am not talking about hypertension complicated by other diseases. What should be the stepwise approach? This has been advocated by the International Society of Hypertension, and also that has been endorsed by the WHO this year. We can use stepwise approach. At first, we have to use or consider combination pill, single pill. That is the one drug containing two molecules, two pharmacological agents in low doses. You can ask me that my patient is having just borderline hypertension. Should we start with two drugs? Yes, the current recommendation is that we have to use two drugs at the same time, but maybe as a half tablet in lower doses. And if this is not adequate, then we have to proceed to step 2. What step 2 means? Step 2 means we have to just use the full dose, recommended dose of the combination pill. And the combinations are preferably ACE inhibitor or ARB plus calcium channel blockers. And if with recommended full dose, the pressure is not still under control, only in that case we can jump to step 3. And in case of step 3, 3 drug combination should be used. And those 3 drugs are the former 2 drugs, and that should be supplemented by diuretics. That is, diuretics should be added. And whenever we are entering into step 4, I am talking about resistant hypertension. In that case, along with use of the previous 3 classes of drugs, we have to use spironolactone. This spironolactone is a very important and very excellent drug whenever we are trying to control blood pressure, but often under-recognized, underutilized, underused. So we have to change our mind to use mineralocorticoid antagonists in case of resistant hypertension or difficult to treat hypertension. The latest 2 guidelines just speak in the same manner. I am talking about ISH, International Society of Hypertension, and WHO. The recommendations are more or less similar. Money is everything. Sometimes my patient may be a very poor one, and he or she cannot afford the standard regimen. In those cases, we have very few options nowadays because the pharmaceutical companies are not interested to market the low-priced medicines now. We have only nifedipine or diuretics like hydrochlorothiazide and triamterene, and sometimes enalapril and atenolol, propanolol, and losartan probably, though not so cheap, are available for treatment of poor patients. Target BP, there are some changes in the ideology of target BP, and after the availability of the sprint trial, the cutoff point for target BP has been set at a lower level. And the target BP is, in general, by WHO guideline, less than 140/90 millimeter mercury, and in presence of high target organ damage or CVD, diabetes, CKD, and high-risk patients, the target BP is based on the systolic blood pressure according to WHO, and the cutoff point is 130 millimeter mercury. Follow-up, in case of just initial phase, monthly follow-up is recommended, and after the relatively control of the blood pressure, the recommended follow-up should be every 3 to 6 months. Just a few words regarding hypertension in pregnancy. We know that alpha-methyl dopa is the time-honored drug. This is still correct, but the favored drug is probably labetalol. Labetalol is the favored drug nowadays. And the next one is calcium channel blocker. And the third one is methyl dopa, alpha-methyl dopa. You will be astonished that, and probably some of you may have noticed that there is some changes in the approved drug to be used in hypertension and pregnancy. I am talking about verapamil. We were taught that, and until recent past, I know that verapamil as diltiazem are contraindicated in pregnancy. But if you look at the recent WHO guideline, verapamil has been approved to be used in pregnancy and hypertension. COVID-19, all are same, non-COVID like non-COVID. So I am almost at the end of my presentation. What I like to say that there is a recent paradigm shift, and this favors drug treatment even in mild hypertension in presence of high cardiovascular risk or diabetes, CKD, CVD, and target organ damage. Calcium channel blockers, ACE inhibitors, or angiotensin receptor blockers, and diuretics are unequivocally the first-line drugs in general, and single pill combination is now preferable. Treating hypertension is not all. Achieve the goal. This is the most important to all. Otherwise, you will not harvest the maximum benefit by treating the hypertension. And the BP target is, in general, less than 140/90 millimeter mercury. And in case of high-risk features, this is systolic blood pressure less than 130 millimeter mercury. And please address other cardiovascular risk factors and diseases comprehensively. Otherwise, the benefit will not be optimum. With this and with the greetings of saffron flower, I like to end my today's talk. Thank you all.